Hi, my name is Raphael Sun. I'm a pediatric and fetal surgeon at Oregon Health and Science University in Portland, Oregon. And I want to thank APSA for giving me the opportunity to talk about twin-to-twin transfusion syndrome. So, twin-to-twin transfusion syndrome, TTTS, occurs in 9 to 15% of the time in monochorionic twin pregnancies. And it typically manifests itself and become clinically evident between 16 and 26 weeks of gestation. And the underlying pathology is usually explained by an unbalanced circulatory sharing between the twins. So one twin is identified as the recipient twin, and the other one is the donor twin. So blood is shifting from the donor to the recipient, and the recipient is getting more blood volume. And the opposite is true for the donor, where they're shunting blood away from them. And so on all monochorionic twin pregnancies on the surface of the placenta, you can see two cord insertions, and there's these vascular connections that come out of them. And so there can be a vein to an artery or an artery to a vein, an artery to an artery or a vein to a vein. And here's an image of the placenta. You can see the two cord insertions, and there are these branches coming out like roots from a tree trunk. And you can see the vascular equator over here that's starred, and this is the vascular connection between the two twins. And on a closer level, you can see that these vessels are touching, and these are the vascular connections that are the etiology of these imbalanced blood flow. So, in order to diagnose TTTS, number one, you have to establish the chorionicity. It should be monochorionic twins. They could be diamniotic or they can be monoamniotic, but usually it's diamniotic, meaning there's two sacs. Second, you have to see a fluid discrepancy in the two sacs. So the recipient twin has a maximal vertical pocket greater than or equal to 8 centimeters, and the donor twin has a maximal vertical pocket less than or equal to 2 centimeters. Third, you can stage them based on the fluid discordance and whether you see a bladder or not. And I'm going to go further into details on how to stage. And lastly, you want to see whether the cervix is shortened or it's closed or if it's funneling or not. And so, by and large, most of us use quintero staging to categorize the severity of TTTS. So, stage one is where you see that fluid discordance, where the donor sac has less than 2 centimeters of fluid, and the recipient sac has polyhydramnios, 8 centimeters or greater. Stage two is where not only do they have the fluid discordance, but now the donor sac has almost no fluid and they're so volume depleted that they're not able to actually generate any urine. And so the fetal urinary bladder is not able to be seen in over 60 minutes. Stage three is where you start seeing Doppler abnormalities, specifically absent or reversed end diastolic flow of the umbilical artery, or you can see absent or reversed A wave in the ductus venosus, and occasionally you may even see umbilical vein pulsatility. Stage four is where we start seeing hydrops in one or both twins, and stage five is a demise of one or both twins. So here is an image showing stage one, where you can see the recipient sac having about 9 centimeters of fluid, so polyhydramnios. And then over here in the bottom right, you can see the donor twin, where the membrane is wrapped around the twin and there's not a whole lot of fluid, and this is less than 2 centimeters. However, they still have a bladder. Stage two is where we don't see that bladder anymore, and you can see here in the bottom right corner that this twin is actually stuck, where the membrane is shrink wrapped around the twin. It used to be called stuck twin syndrome, and now you can see that it's defying gravity because there's just no amniotic fluid in that donor sac. Stage three, where you see Doppler abnormalities, you can see over here that there's the absent end diastolic flow of the umbilical artery. Stage four is when we see the hydrops. So you can see some skin edema, scalp edema, some ascites here. So in general, outcomes without treatment, if you follow the natural course of TTTS, if they continue to progress, 90% of the time they'll lose the entire pregnancy. So here are the treatment options. Expectant management is one of them, where you can just continue to do ultrasound surveillance and see if they progress to more advanced stages of TTTS. Sometimes they may just stay at stage one TTTS. Termination of pregnancy. Serial amnion reduction is an option where you're taking fluid out of the recipient's sac, but you're not really treating the underlying etiology and the pathophysiology of TTTS. There is selective laser photocoagulation or laser surgery of the communicating vessels, where you're able to coagulate those connections and stop that process of TTTS happening. And in general, we're offering laser surgery for stage 2 through stage 4, and some centers may offer laser surgery for stage 1 TTTS, and it would depend on different circumstances and criteria. And lastly, there's umbilical cord occlusion, where you're doing a selective reduction, taking a twin pregnancy and turning it into a singleton pregnancy. Here's a landmark paper published in the New England Journal of Medicine comparing amnion reduction versus laser surgery. And what they found was laser surgery was more effective first-line treatment compared to serial amnion reductions for twin-to-twin transfusion syndrome. Just briefly here, you can see that when you're looking at least one survivor, the laser group did much better compared to the amnio reduction group. So here is a video showing what laser surgery looks like. This is a camera using a 2 mm scope. Sometimes it can go as small as a 1.3 mm scope. And you can see how like it's very different than normal pediatric laparoscopic surgery. There's a lot of particulate matter, which is normal. Here you can see on the placental surface these vascular connections, and there's a shade that's different on the screen left, and that's the membrane. So the membrane is shrink wrapped around the donor sac, and usually the vascular equator is around there, but you can't really rely on the membrane always. And so here we're tracing the vessels all the way back to the recipient cord, and I'm confident that the vascular connection right here is between the donor and the recipient. And what we're doing is we're identifying those vessels and doing laser photocoagulation. So with every surgery, you have to weigh the risk and the benefits. The risk of the procedure itself, you can experience loss of one or both twins in about 10 to 15% of the time. A huge risk of fetal surgery is membrane separation, and that's where the amniotic sac peels away from the uterine wall. And that's an increased risk for PPROM, which is premature preterm rupture of membranes. And that can happen about 30 to 40% of the time, which could also lead to preterm delivery. After laser surgery, there's a small population that could have TAPS, which stands for twin anemia polycythemia sequence. On the other hand, the risk of the natural history, if it progresses, we mentioned earlier that 90% of the time they can lose the entire pregnancy. And there's a theory that if you have an in uterine demise of one twin, it could actually affect the other twin, either by death or neurologic impairment. And the risk of natural history is they could just miscarry and deal with, or deal with extreme prematurity. And so how does laser surgery help resolve TTTS? Well, it turns a monochorionic placenta into a functional diachorionic one. And this is the placenta after laser surgery. You can see the two cord insertion and the membrane right here in the middle. And what I did was I did what we call a solemnization, where we go from one edge of the placenta to the other, making sure that there's no missed connections and that every single vascular connection has been ablated. Here's another example. You can see between the donor and the recipient, these are marks of having laser photocoagulation done. So here are the outcomes for TTTS. In a 2020 systematic review and meta-analysis, you can see that they looked at survival in all stages. At least one twin survival occurs in about 86 to 87% for stage 1 and stage 2, and it drops a little bit for stage 3 and stage 4, but overall still really good outcomes and percentages for at least one survival. When you're looking at dual survival, for stage 1, stage 2, it runs anywhere from 65 to 70%, and for stage 3, stage 4, it's about 50 to 60%. And a lot does have to do with the estimated fetal weight, meaning that if there is one twin that has selective fetal growth restriction, that can also play a role in terms of having dual survivors. And the estimated gestational age of delivery is about 31 weeks, 30 to 31 weeks across the board. So in summary, TTTS occurs up to 15% of monochorionic twins. Laser surgery of the placental anastomosis can change a monochorionic placenta into a functional diamniotic placenta, stopping this transfusion process from happening. And whenever counseling patients, you must consider the risk and the benefits for all fetal intervention. Well, I hope you learned something from this short lecture, and thank you for your time.